Invite our next speaker, Dr. Kanika Bharadwaj. She will be speaking on the third wheel extra procedures.
A very good afternoon to one and all. So, in keeping with the theme of today's instruction course, I would be just introducing the extra procedures to the audience. And I would like to disclaim here that I'm not either in favor nor against these procedures. So, what are the extra procedures? In a refractive surgery practice, the most dreaded complication is the post-refractive surgery ectasia. And hence, most of them are refractive surgeries are very safe and effective, we do have certain limitations. PRK, LASIK, and SMILE are the most common things in our armamentarium these days, and they're still not immune to complications. There could be regression after the post-op period, or there could be iatrogenic induction of ectasia. Biomechanical stability is the concept behind all these problems, and we do know that all these procedures are subtractive procedures, and thus they do take away from the cornea and its strength. So like in PRK, there is an injury to Bowman's membrane, and in LASIK and SMILE, there are creation of vertical delamination cuts, which again reduce the strength. It has been noticed in multiple studies that corneal weakening after laser vision correction is definitely there. There is about 14 to 33% corneal weakening just by increasing the flap thickness. So we can see here that 180 micron flap will have more weakening as compared to an 80 micron flap. Now coming to extra procedures, what is extra? Extra means we are doing a simultaneous corneal collagen cross-linking along with the refractive surgery. Now, corneal collagen cross-linking has been long in vogue for corneas that have been diagnosed as having keratoconus or even ectasias. So this therapy is proposed as a prophylactic or an adjunct to corneal refractive procedures. So at the one hand, where we are deleting a tissue, we are also providing some additional biomechanical strength to the treated cornea. So this is to prevent any future ectasia, especially in borderline corneas. So the procedure involves conducting the refractive surgery followed by an accelerated protocol of the corneal collagen cross-linking. So extra procedure can be combined with PRK, LASIK, and SMILE, all three. Apart from the biomechanical advantage, simultaneous cross-linking can also lead to less epithelial thickness increase post-operative, which is also implicated in the regression post-operative period. So this picture shows a control cornea which has not been cross-linked. On the right, we can see a cornea which has been cross-linked. So we can definitely see the integrity, the strength, and the holding of the tissue is better after cross-linking. So it restores strength, it improves the flap bed adherence, and also gives a better tensile strength. It also reduces regression and risk of ectasia. Now, is it suitable for everyone? The answer is we don't know yet, but still there are a few indications where we should definitely consider giving this as an option to our patients. So it could be the thinner corneas. There's no arbitrary number, but usually people take it to be less than 500 microns. High myopia, more than 6 diopters, where we need more of tissue subtraction, family history of keratoconus, or any topographic asymmetry noticed on the tomography maps. If there is difference in astigmatism between the two eyes more than a 0.57 diopters, and young patients who can have unstable refractive errors, hyperopes, as again because it prevents regression. There's also a paper in Indian Journal of Ophthalmology similarly citing various criteria how to decide upon whether a patient has to be taken up with for extra procedures or a refractive surgery alone. So coming to the types, PRK extra, very commonly performed if preferred amongst the extra procedures. It is for patients with borderline corneal thickness where it might not be very safe to go ahead and perform a flap surgery or a SMILE surgery. Corneal collagen cross-linking is performed after performing the PRK, or enhancement is needed, or when the surgeon wants to strengthen the thin cornea which is noted preoperatively, or if there's any asymmetry, if there is against the rule astigmatism or even steeper looking corneas. So the procedure involves a similar protocol. Epithelial debridement can be done by any of the methods like alcohol delamination or scraping, following which the excimer laser treatment is fired, then is soaked with isoosmolar riboflavin. Now here the dye that we used is mostly in vehicle either as HPMC or saline. We do not use dextran based dyes here. and it is soaked for about 90 seconds, followed by a UVA exposure at 30 milliwatt per centimeter square for 90 seconds. So the total energy that is delivered in this procedure is half of the conventional dose, which is 2.7 joules per centimeter square. At the end of the procedure, mitomycin C is applied and then washed, and BCL is applied. Now what is next? Next is the LASIK XTRA. So what are the mechanics here? So after the excimer laser has been used to reshape the cornea during a LASIK procedure, a small amount of specially prepared dye, such as one by the name of Vibex, which contains again saline, not the dextran, is applied for 90 seconds, and the protocol similar to the PRK1 is followed. So the images here show the protocol being followed. Now important here is to not get the flap in touch with riboflavin dye, so we want to avoid that. There's just a small video of the same. So after creation of the flap and raising the flap, the excimer laser is fired. Now riboflavin soaking in isoosmolar concentration is done. It is then washed. The flap is repositioned, and then UV exposure is done. So this is just an idea about LASIK XTRA. Of course, the risks related with the corneal collagen cross-linking, such as haze, do exist. Safety of LASIK XTRA, there have been multiple studies. The manufacturer Avedro has also conducted a big study where they included about 52,000 eyes in Japan, and they concluded that overall the vision in patients who underwent XTRA procedure and who did not undergo XTRA procedures was similar at the end of procedure. So it has been deemed as a safe and effective procedure. Coming to SMILE XTRA, SMILE is the latest, and it is performed as per the standard protocol, that is after delamination of the anterior and posterior laminas, lenticule is extracted. Now the space that is created after lenticule extraction is then filled with 0.25% riboflavin in saline, which is injected and allowed to diffuse for about 60 seconds, after which it is rinsed off, and over this we then go ahead with the UVA radiation in the similar dose that is delivered as per other XTRA procedures. So this is a video of the SMILE XTRA, how it is done. So here we see docking and the laser being fired, creating anterior and posterior laminas, separation, the lenticule is then extracted. Now this is followed by injection of a riboflavin dye. So usually in our center we do it at the same sitting. As soon as the SMILE procedure is over, a 60-second soak is given, and after rinsing off the dye, UV exposure is done. So I would like to conclude that corneal collagen cross-linking, which is an already proven procedure to improve the biomechanical strength, can also be used in prophylaxis with refractive surgery procedures in order to give strength to those corneas lying on the borderline limit for refractive correction, or the ones giving us confusion in our clinics. It also works by creating additional chemical bonds between the various proteins and the collagen in the stroma. Both ectasia and regression are supposed to and postulated to occur as a result of biomechanical changes affecting the strength, and hence this procedure theoretically should impart more strength and thus reduce these risks. Comparative studies have shown that combined surgery and simultaneous cross-linking has similar or better efficacies, but long-term studies are still warranted. We also have to know that while performing these procedures, there are still risk of complications such as development of post-operative ectasia even after this procedure, which is possible. Therefore, flapless procedures are preferred, such as PRK and SMILE. LASIK, due to the induction of vertical cuts and more tissue subtraction, flap also does not contribute to the strength, so is less preferred if compared. Haze definitely is more in PRK, has to be kept in mind the flapless surgeries are again better preferred. There is always a risk of over and under correction if there is too much of drying or too much of UV exposure, or there is irregularity in the irradiance. So that also has to be kept in mind. Nevertheless, these procedures are there and are available in our armamentarium. So we should keep them in mind when we are offering refractive surgery to patients, or when we are straight away going and rejecting them. Probably we can give them a chance. If anyone has already started working on publishing data, we would like to read their results. Still, I would say that long-term studies are warranted to deem these procedures as entirely safe.